Hi, my name's Dr. Greg Pearson. I'm an adult psychiatrist in private practice.
Hello, I'm Dr. Matt McDornan. I'm also an adult psychiatrist in private practice.
Today, Matt and I are going to have a conversation about antidepressants. Matt, it's difficult to know where to start with this.
Yeah.
But there's sort of mixed feelings about antidepressants, I think it's fair to say, in the general community.
That's right, yeah. I guess I'd start by saying that the word antidepressants is a little bit of a misnomer.
Absolutely.
In that we use them to treat clinical depression, but we also use them to treat a variety of other conditions, such as anxiety disorders, some pain syndromes, sometimes eating disorders. So lots of medications have multiple uses. If you think of aspirin, you can take it for a headache, but a cardiologist might use it for heart disease, or a neurologist for some forms of stroke. And I guess that's where we're talking. So we'll talk about the medications, the drugs themselves, and how they work and what the experience of being on them is like. But remember that there's more than one use for them.
So Matt, their mixed reputation, I think, comes from two factors. One in particular is the notion that that they may not be particularly effective in the treatment of depression. And the other, I think, is that they're difficult drugs to stop. I would certainly agree with the latter.
Yes.
But as a psychiatrist, we prescribe and stop antidepressants all the time, and I personally think if that is done carefully and in a considered way, stopping antidepressants is not a difficult process.
No, it can be done with support, can't it?
It can be done appropriately with support.
Yeah.
But the issue of their efficacy, I think, is really interesting, and I think that harks back to something we talked about in one of the very early videos about depression, the diagnosis of major depression being a very, very broad category of illness. And that contained within that broad category are depressions that do not require antidepressant treatment in the form of antidepressant medication. They lend themselves much better to psychological therapy. Conversely, at the other end of the spectrum, the more severe illnesses, and as a psychiatrist I can only speak from my personal opinion, I think antidepressants are incredibly helpful treatments for people whose depression is largely driven by biology.
Yes, that's right. Absolutely. And I would agree with that, Greg. And in the big meta-analyses, those kind of concepts aren't particularly teased out.
No, that's right. And
so a meta-analysis is combining lots and lots of different studies and looking at the efficacy and effect size of antidepressants. And there's been a number of contentious attempts to do this with varying levels of confidence that antidepressants work. And they haven't really been able to pull apart the notion of the depressions, is really what we're saying. If you've got a melancholic severe depression, you're more than likely to respond to antidepressants.
To biological treatment, that's right. And as a clinician, I find them very useful medicines.
Yes.
I think the other concern people have about starting antidepressants is that this is potentially a mind-altering process, that there may be something occurring as a result of the prescription that changes them in some way.
Yeah, it's an interesting way to look. If we talk about depression, I find it sort of an inverted argument. People say, they are a band-aid, or they're covering up parts of self. If you're depressed, your self is partly covered up. So we endeavour to remove the depression and then access true self. That's not to say that antidepressants don't cause some changes in people's ability to access emotions, and we'll go on to talk about that. But just as a kind of broad concept, I still think that the argument's the wrong way around in some people's mind.
Yeah, absolutely. And no doubt there are people who've been treated with antidepressants and have not responded or not had positive effects from the drugs. And I think we always need to be mindful of the fact that for a proportion of people, they can get worse on antidepressant medication. That's something we need to be alert to at the time of prescribing.
Yeah.
Sadly, we can't predict who those people are very accurately. We do, as we mentioned earlier, have access now to what's called pharmacogenomic profiling, where we can look at someone's genetic pharmacological coding to see if they will metabolize the medicines effectively or not. And we can also look to some degree at the level of penetration that these drugs will have into the central nervous system, which varies from person to person as well. Typically, we wouldn't automatically go to a test like that, which is quite expensive from the outset, but in the event that someone was struggling to find some medicine, that would be available.
I think that's right, but given that we're left without the ability to match an antidepressant to a particular kind of depression with any kind of testing, most of the time we're left with symptom management. So within a depression, people can have different problems. So some people can't sleep, some people are fatigued, some people have a suppressed appetite, some people comfort eat, some people can feel agitated, other people feel slowed down, and you can try and marry how we know antidepressants work or what their effects will be to the particular symptom load, and that's I suppose the discussion that we have with patients, trying to understand where their particular symptoms are more dense or less dense and marry the drug to that. Again, it's imperfect though.
No, but that's beautifully described, Matt, and I think that's what all good clinicians do, is try to make an informed decision about which drug to use. Ideally, it would be like prescribing antibiotics, where we had some sort of evidence that the bacteria was sensitive to that antibiotic and we could predict with certainty that it would work, but in psychiatry we don't have that level of diagnostic certainty. So it does emerge as a trial and error situation, but it needs to be informed depending on the patient's presenting symptoms and what we do know about the way those antidepressants work.
And we do have to mention, even briefly, this isn't a complicated discussion on their actual mechanisms, but people do talk about serotonin deficiencies and so on, and just to kind of broaden out just a bit how these drugs work. Can you talk to that, Greg?
Yeah, absolutely. There is no evidence to support a serotonin deficiency.
Yeah.
It would be lovely if we could do a blood test and demonstrate that serotonin was deficient, and if we enhanced the level of serotonin, things would improve. It's a much more complicated process than that. Mood is determined by a whole variety of factors within the central nervous system. But there are a group of medicines called the serotonin reuptake inhibitors, popularised by fluoxetine or Prozac, which emerged on the scene in the very early 1990s, and sadly it was such a novel compound and it was so effective in treating the more minor depressions and in treating anxiety that it became incredibly popular in the United States, and I think largely resulted in a bit of a backlash against the use of that compound because it was invariably overused. But we've now got nearly 10 of those medicines available, and they're all helpful in differing ways. The one thing I would say about this, about antidepressant treatment, and I think you have to be alert to this if you're starting on antidepressants, is that they take a few weeks to work. The earlier that we see some benefit from the drug, the better it bodes for your response to the medicine, and some people can respond to these drugs very quickly, but in general we'd like to see a response by 2 weeks. That doesn't correspond to elevations in level of serotonin.
No. Yes, that's right. So, I mean, we're talking about manipulating a number of neurotransmitter systems, aren't we?
Yes.
Ultimately. So
Yeah.
serotonin and noradrenaline and dopamine, and then more recently, melatonergic systems. So most of the antidepressant groups are affecting these systems. The drug is absorbed and has an effect quickly, which is more correlated with the side effects we see in the first couple of weeks.
So nausea,
Yeah,
headache,
yeah,
insomnia,
yeah,
sometimes diarrhea,
that's right.
and agitation. A lot of serotonin receptors in the gut.
Yes. So that's an important point. You have side effects often before you have any clinical benefit, and people need to be aware of that. Most of the time they're annoying and manageable, and they peter out by a couple of weeks after starting the treatment. And then, the neuroscience suggests a whole series of different things that are happening in your neurons the underpinning of an antidepressant effect is ultimately microstructural. That is the way neurons are talking to each other and interacting. A lot of that is yet to be determined. But the timeline means because they're micro changes, we see the response from 2 weeks onwards. And it's not a uniform response, is it?
No, that's right, Matt. It varies from person to person and varies from illness to illness as well. But that's right, we do know that response correlates with dendritic growth and an improvement in brain volume in the areas of the brain that are affected by
and
depression.
Think about it, that's got to take time because it's microstructural. The other thing is that these are not on-off responses, so people don't really ever step straight up out of depression on these drugs, do they? It's more like a jagged edge climb up.
That's right. Ideally, that's right. We like to see a gradual improvement over time, and sometimes that is stagnant and rather sawtooth.
Yeah.
And sometimes people improve and slip back a little bit as they move along the treatment path. But the general trajectory should be towards improvement.
That's right.
We get a bit nervous where there's a sudden improvement.
Yes.
And
or a change.
And we can see that in a variety of circumstances. The one we have to be very alert to is bipolar disorder, that there has been a switch in mood induced by the antidepressants, but some people do respond to these drugs remarkably quickly.
The other thing is if we look at what depression is, low mood, inability to access pleasure, an array of depressive thinking patterns, sleep problems, energy problems, appetite, libido, those things don't all march together like a line of soldiers in an old Napoleonic war scene or something. Some of them go forward first and others lag behind. So, it's you have to keep people under review to check where they are. And I think that, they're not the kind of medications that you can just give someone and then not see them. They require review and constant clinical understanding of where someone is in this process.
Yes, and there's a few things along the way there that will inform our further prescription of medicines. Tolerability is an important thing, and the intolerance of an antidepressant is important information in and of itself. It will sometimes direct us in terms of further prescribing because of understanding what might be causing that intolerance unique to that particular compound.
That's right.
The issue of response is an important one. Partial response suggesting we may need to increase dose. No response meaning we may need to be looking for an alternative compound.
Yeah.
And occasionally we see some very funny effects from a drug, which just means it is not tolerated by that person, and we really need to be alert to what mechanism that might have uncovered.
So there's a couple of different timelines to consider here. There's the side effects that go at the start, and then even when you're on an antidepressant, there can be side effects that remain or develop once you're even stabilised on a medication, can't they?
Yeah, that's right, Matt. So I mentioned the serotonin reuptake inhibitors. We will often, after using one of those, use a serotonin and noradrenaline reuptake inhibitor. Other common medicines are called NASA's noradrenaline-specific serotonin antidepressants, and more recently a melatonergic antidepressant. But a lot of those drugs will have a very similar side effect profile. And there's really, to my way of thinking, two problems associated with the longer term side effects of those drugs. And that is libido and sexual functioning.
Yeah.
So we know that as you drive serotonin up, this can have a negative impact on the issue of libido, the desire to engage in sexual activity. And for some people, that can be really problematic and distressing. The other element of that can get affected is the capacity to achieve an orgasm and derive a normal level of pleasure from sexual activity. So unable to orgasm or a diminished experience from the orgasm of pleasure is, again, not an uncommon situation. And for some people, that's a godsend if they get aroused too quickly and they derive benefit from the drug, and for other people that can be a real problem. Certain antidepressants don't do that. And perhaps another thing I should mention is the issue of weight gain, that some people can gain weight on these medicines, something we also have to be alert to.
And fatigue.
Yes, and fatigue.
The other, I guess, group of side effects that are very hard for people to describe, but are fairly common, at least my patients talk to me about, is a sense of not having a normal relationship with your emotional range anymore.
Yeah,
So
that's right.
It's a nebulous sort of realm of emotional dissociation, feeling like you're aware intellectually of emotions, but they're not coming to full expression.
And for some people that's devastating, and for some people whose level of emotionality is exaggerated, that can sometimes be a beneficial experience.
Yeah.
But again, yes, that emotional clipping or emotional numbing can be problematic. And it also, that experience can play into the issue of stopping medicine as well. So when a dose is reduced, and perhaps we could move on to talking about, typically someone with a depressive episode would be on medication roughly for 12 months after their first episode, and with subsequent episodes that would be a longer duration. But after that time, we would look to taper down and stop the antidepressants, and that can induce problems of its own.
Yeah, that's right. People get very anxious about this. Stopping antidepressants, I often get asked by people, are these substances of dependence because the effect is so palpable? And my analogy really is like one of insulin. If you had diabetes and your blood sugar was stabilised on insulin, and then you suddenly stopped insulin, your blood sugar would move around and you'd feel pretty terrible. It's a physiological process. It's the same with antidepressants. You can lower them slowly and taper them off, and that's a much better idea than rapidly ceasing something.
Yes.
For that reason, even some people, when you're going slowly down, they experience a flu-like state. Depending on the drug, they can experience all sorts of unusual experiences like jerking or electric shocks or tapping in their head. And
the so-called brain zaps.
Yeah, and then also a slight sense that your vestibular and visual systems are slightly out. If you move your head quickly, it takes a split second for your vision to catch up.
Yeah, that's right. So people will describe it like their brain is an egg yolk.
Yeah.
And they move their head and it lags behind.
And these are annoying and not dangerous. There's no neurological emergency here, and they do tend to resolve. It just takes time, as in weeks.
That's right, and they can be managed as well.
Yeah.
There's ways of improving the severity of that response. But Matt, perhaps more troublesome for people, particularly if they stop antidepressants abruptly, is not just these they're called discontinuation symptoms. To my way of thinking, they're a withdrawal phenomenon.
Yeah.
But the issue of a rebound of emotional activity.
Yeah.
And This is the opposite of the emotional clipping that's happened during the experience of being on antidepressants, where it's difficult to feel emotions. All of a sudden, emotions are returned, but with an exaggerated intensity. And that can include sadness and depression and tears, but it can also include irritability and anxiety. And for most people who are stopping medication, this serves as a great warning to them, and they may immediately interpret this as being a relapse, and quite commonly then will terminate the process of withdrawal. But in actual fact, it is part and parcel of the withdrawal process as well.
That's right. These are complicated drugs. Each drug has its own particular characteristics, and it's really up to you with your psychiatrist to go through this in a lot more detail. And this was really just an introduction and broad brush introduction to some of the big themes in antidepressants, isn't it, Greg?
That's right. And I think the take-home message is there's no need to be fearful of them, but they need to be treated with respect, and that their prescribing needs to be informed and monitored.
Thanks for joining us today.
Thank you very much.